MDS Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the MDS Hub podcast. Today we'll be hearing from Amer Zeidan from the Yale School of Medicine in New Haven, US, and Jacqueline Garcia from Dana-Farber Cancer Institute in Boston, US.
Hi everyone, my name is Amer Zeidan. I'm an associate professor of medicine at Yale University, and it's a pleasure to be here with you today in the presence of Dr. Jacqueline Garcia, who is an instructor of medicine in Dana-Farber Cancer Center and who has led some of the work on azacitidine and venetoclax in the frontline setting. There was an abstract that has been presented in the European Hematology Association meeting looking at the heme toxicity and management of those interruptions with azacitidine and venetoclax and how this should be done in the context of therapy for MDS, which we will be discussing today. So maybe to start, Dr. Garcia, can you give us an overview of the abstract and the main messages?
Oh, absolutely. Thanks so much for the introduction, Dr. Zeidan. It's been a pleasure working with you on these trials in the MDS space. It's an incredibly exciting time for patients with higher risk MDS. We have some very compelling clinical trials that have given us evidence for safety and early efficacy with some really active combinations. Here we'll discuss the combination of standard dose azacitidine with shortened course of venetoclax that has been tested in the phase 1b setting, where we've presented the initial safety and efficacy data at ASH over the last 2 years. And here at ASCO 2021, I had the opportunity to present a little bit more data on the hematologic toxicities, which a lot of people are interested in. Just as a background, venetoclax is an oral BCL2 selective inhibitor, and in combination with low-dose cytarabine or hypomethylating agents, it's already approved for older patients with AML who are not candidates for intensive chemotherapy. That approval was based on high complete remission rates and improved survival that was seen with the HMA combination. On the heels of that success, we have been so eager to find evidence for therapies that could be used in higher risk MDS, where in general, the standard of care has been predominantly hypomethylating agents or going right to transplantation. As most of our patients are older, we just need more therapies. And what we have been finding in the context of this clinical trial is that azacitidine plus a shortened course of venetoclax can indeed be safely given and has a really impressive response rate. So I'll present that and a few of the safety modifications that we have done to make a trial like this possible and show what we've been doing such that a phase 3 study has since been launched so that way we could try to demonstrate that this could be safely done in academia and in the community, and hopefully that this will eventually lead to an approval. So in terms of the background of this study, this phase 1b study has roughly 78 patients involved where venetoclax was combined with azacitidine. As with all phase 1 studies, we had to first dose escalate venetoclax and add it to the standard of care azacitidine. So during dose escalation, venetoclax was increased from a low dose of 100 to 200 to 400 milligrams. And initially, venetoclax was given continuously as it was done in AML, but we quickly learned after some complications in patients that were very serious that we could not mirror what we do in AML and MDS. And since that very big change to the protocol over the last 2 years, we have since then been giving a modified schedule that is much more appropriate and has demonstrated safety in the high-risk MDS setting. And that includes giving venetoclax instead of a continuous dosing of 28 days per cycle. Each cycle is 28 days in general. We now give it for 14 days on and 14 days off. What we've been able to establish, because an MTD was not reached, is that the recommended phase 2 dose of the combination is azacitidine, a standard dose of 75 mg per meter squared, days 1 through 7, plus venetoclax, 400 milligrams, days 1 through 14. This clinical trial includes patients with an IPSS score of intermediate 2 or higher for MDS. Bone marrow blast had to be less than 20%. Patients had to have an ECOG score of 2 or better. And this was a study for adults only. What was important is that the study was set out to establish the safety, which we have since proven and demonstrated. but now we're trying to show some longer term responses and survival benefit. At ASCO this year, had the chance to discuss what we did in the safety expansion cohorts. There were two cohorts that were presented. Both had received the combination therapy with the 14-day venetoclax cycle. But what was different about the two cohorts was that how we chose to dose modify based on adverse events that are hematologic in origin, such as neutropenia or thrombocytopenia. It was different in each cohort. So we wanted to review what happened to those patients in case we could learn or see that maybe dose reduction strategies might be better in one way versus the other. What was very limiting about this study and analysis is that there was only about 20 to 22 patients or so in each cohort, and the follow-up time was about 6 to 7 months. So definitely with more patients, longer time, I think we'll learn even more. But very early on, we were able to see a few patterns. So with safety expansion cohort 1, investigators were given the choice with how they were going to reduce the dose of azacitidine or venetoclax in terms of which one to reduce first. We did it based on investigator judgment, based on prolonged neutropenias, based on delay in cycle lengths, and investigators would choose to reduce AZA by 33% or venetoclax dosing by 50%. If that was not sufficient for subsequent cytopenias that were then prolonging a cycle length, investigators would then shorten venetoclax from 14 to 9 days. As you can see, that type of strategy is a bit cumbersome, but we left it to investigators at that time to make the choice. With much more maturity and changes to the protocol, safety expansion cohort 2 gave a more regimented approach where we reduced azacitidine before venetoclax, essentially using the package insert or the USPI guidelines. And in that way, we would essentially reduce azacitidine first based on cellularity and count recovery. And then after that was done with subsequent cycles, if there was still any leftover cytopenias, venetoclax dosing duration would then be changed from 14 to 7 days. So we were essentially comparing investigator choice, essentially people that had a lot of experience using the combination, to a protocol regimented reduction in a small cohort. There were no real differences in baseline characteristics. And when we took a look at what happened to patients and the doses that were subsequently administered in these two safety expansion cohorts, we saw with a similar median follow-up time that in general, patients received the same amount of therapy, meaning that patients did not necessarily come off therapy sooner based on one strategy versus the other. And we saw that if you reduced azacitidine before venetoclax, then venetoclax reduction subsequently did not need to happen. So what was really neat is that when you compare the two cohorts, and the numbers are very small, so that does limit, we do see that the median time to dose modification in general is about 120 days. So that suggests that azacitidine is not yet reduced until about 3 months or 4 months into treatment. And when you reduce azacitidine first, in the patients that were treated in cohort 2, venetoclax ended up not needing to be reduced unless it was recommended by protocol based on drug-drug interactions. When investigators chose to dose reduce one versus the other, where they were giving leeway in cohort 1, what we saw was that there was more opportunity for venetoclax dose reduction, and that more than one reduction might have happened to patients. So with a more quote willy-nilly approach, there was just a little bit, there was more inconsistency seen compared to the protocol-defined modifications. When we took a look at response rates, we saw that overall responses were roughly 86% with the CR and marrow CR overall, which was really compelling. And though the number of patients in each cohort is small, the actual CR rate was 32% versus 24% in cohort 1 versus cohort 2. And that's just really based on just a couple of patients. I think it's too early to say that one strategy is better versus the other, because overall the response is really compelling and still very good. In terms of the adverse events, the GI events looked roughly about the same. And in terms of the hematologic toxicities that were of concern, like febrile neutropenia, the rates were fairly similar. The infection rate looked to be maybe a little bit more in cohort 1, where investigators got to choose what to reduce first. And overall, what's really important to know, knowing that infections and leukopenia might be more frequent when investigators were choosing what to reduce versus reducing AZA first. We see that the serious adverse events were pretty comparable. Now the N is very small. What's important to know is that in this clinical trial, antibiotics were absolutely required during cycle 1 and anytime neutrophils were less than 500. And that's important for anyone that might use this therapy off-label, which we're not recommending. It should be used in the context of a clinical trial when possible, please, or until the data is much more mature. But the use of antibiotic prophylaxis did help to curb serious side effects and help to curb serious infectious rates. When we try to look at a deeper detail of neutrophils and platelets over time on study, what's really notable is when you compare the two, and this is actually my favorite figure in the poster, where you look at the neutrophil and platelet level. When you compare the two cohorts, in general, after cycle 4, the levels are pretty similar between the two groups. And when you're looking at the depth of neutropenia, it's predominant in the first 2 cycles. And once you're beyond cycle 2, most patients have neutrophil counts above 1,000. Now, all of us in general care about counts, but in reality, it's when neutrophils are less than 500 when we're more concerned for infectious-related complications. And that depth of neutropenia happens less and less over time, especially after the first 2 cycles. And that is also when responses happen. Responses happen about 2.5 months in. So that tells you if you can safely take a patient through therapy with a 14-day venetoclax cycle, you are able to prophylax them. You can then help them to get through the neutropenia that's required and expected, and hopefully get them into that high response rate category that most of the patients got to enjoy. When we took a look at the platelet counts, we saw that in cohort 2, in the first 3 cycles, there was a slightly decreased platelet level compared to cohort 1. But when you look at the numbers, they're all above 50,000. So most of the platelet levels, I think that a lot of the issues with our presentation there is the access and the level. The platelet levels are still very reasonable and safe and not severe, suggesting that the platelet levels are fairly comparable between the 2 cohorts, and that resolution of any of those cytopenias happens after the first 3 cycles, which is reassuring. We still don't have a great handle of Neupogen use that really is investigator and site specific. And I think that you'll see that in general with MDS, it's a practice specific use. The protocol was really nice. It allowed us to use Neupogen if required based on profound hypocellularity, prolonged cytopenias to help reduce infectious complications. And what we were not able to fish out was whether or not patients that essentially were on Neupogen from the beginning, did they stay on it throughout, or were these individual events? Because we took a look at Neupogen use, but we couldn't tell if they were the same patient that was essentially receiving it at the same time. So Neupogen was used in this protocol, and it was not, I would say its use was variable based on site, and that might have helped to curb some of the neutropenia. It was probably used for anywhere from 3 to 8 days, and it looks like the use is very investigator specific. So what we summarized and were able to conclude from this exploratory analysis of 20-some patients with a median of 6 to 7 months is that there were similar acceptable safety profiles, and dose-reducing azacitidine in a more structured approach following the package insert guidelines based on cellularity and counts looked to be a very reasonable and safe approach, especially based on the mechanism of action, where we see that the combination is highly synergistic, and that you might be able to reduce azacitidine to help to promote the apoptosis with venetoclax.
Thank you. Such a great summary. So maybe a couple of clarifying questions. So the dose reductions happened only after the patients had achieved a marrow CR, meaning that the bone marrow had to show less than 5%, or some of those reductions also happened in patients who still had increased blast count?
So the protocol actually gave a lot of guidance that responses had to be seen before the reductions could happen. However, if there were complicated neutropenias, a reduction could be warranted as well, and with a discussion with the medical monitor. So what we had essentially been seeing is that when you see hypocellularity with the absence of blast. Now that when we say absence of disease, it's complicated, right? Because we'll still see dysplasia on the bone marrow, but when we see absence of blast and persistent hypocellularity, then azacitidine was dose reduced, especially if the naders were persistent beyond 28 days. We allowed up to 14 days for recovery. And in general, if you look at the median time between cycles, it's about 15 days in between. So if you gave it enough time, people actually were able to recover their counts. So that's one of the lessons learned, is that if they actually get the combination of therapy, you could safely wait 1 or 2 weeks as opposed to keeping them on a 28-day exact cycle and then safely be able to resume therapy. But if the neutropenia or thrombocytopenia was persistent, then you could then reduce, for instance, hypomethylating agent first, based on the cellularity of bone marrow. We actually did require looking at the bone marrow biopsy in order to make a safe assessment for dose reduction. So that way we wouldn't underdose somebody.
So that's very helpful. So to follow up on that point, so it sounds like the response rate in terms of CR were slightly lower than what was reported in the last iteration of this, which I think was around 40%. And here you're 24 and 32%. Again, small numbers. But do you have some concern that some of those below CR responses are not being translated into, I guess, more CR-like type of responses because of the dose reductions? Or do you think that this is the best you can obtain in these patients because of the disease bone marrow microenvironment?
Yeah, I think that it's only going to be with more patients that we'll see what the true full CR rate is. With azacitidine alone, when we had done a systematic review to see what is the azacitidine CR rate, it's roughly very similar to what the AZA-001 shows of about 17%. So here in combination, it's certainly higher. Since our initial presentation, when we look at small cohorts, we're seeing slightly lower CR rates, but I do think that it has something to do with timing of when you do the response assessment and start the next cycle. If you're starting the next cycle just as they're recovering, then you won't get that ANC of 1,000 that you need in order to call a CR. But one of the things I hope to see is that there was actually a third expansion cohort. At the time of this assessment, the data was not available for the similar follow-up time. So I believe it's roughly another 20 patients. We might be able to have a more refined response rate shown. Andy Way was able to present the cumulative data with all of this combined at EHA this year, which still demonstrates a still nice, robust CR rate. So it's not entirely clear to me why it's slightly less. The N is too small, and it really was like 2 patients, I think, that made that difference. So it's hard to know, were they elderly, compared to some of the others. The other thing to note is they lifted the transplant exclusion criteria at this point in the protocol when it was amended. So I don't know if, even though the baseline characteristics are very similar, I don't know if patients were taken off study as soon as their blasts were gone and brought to transplantation, so those are things that we need to learn. And it's an exciting thing that people want to do that. It's because the drugs in combination are able to reduce the blast. So now we're seeing that patients may be able to be bridged to transplant sooner. So that might be one of the things that I'm wondering had happened. Did they come off study a little bit earlier than some of the other patients in safety expansion 1?
Thank you so much. I think this is very interesting, and all of us will be waiting to see how the Verona phase 3 trial pans out with this second approach of the dose reduction with azacitidine. It does seem like the data that you presented suggests that this approach has similar efficacy. So I guess we will find out from the phase 3 trial more about the efficacy and the safety of this very exciting combination of drugs. Thank you so much, and looking forward to hearing more about interesting MDS drugs. Thank you, everyone.
Thank you.
Thank you for listening to the MDS Hub podcast. We would also like to thank our supporters, Novartis and Bristol Myers Squibb.
MDS Hub podcasts, brought to you by Scientific Education Support.